Hello, this is Dr. Gabriel Chu from FVCL. Thanks for joining us for this video. I want to do a quick narrative on a routine cataract surgery where we have approximately a -6 myope, higher axial length patient. We're putting a 12.5 diopter InVista lens in this eye with an LRI to correct for corneal astigmatism. And sometimes with these longer eyes, you can have some high variability with the anterior chamber that tends to be quite distendable, especially when it comes down to putting either viscoat or putting higher pressure of BSS into the eye during the surgery. So I've just made my two incisions, the paracentesis and the main corneal wound. I'm using a 600 micron LRI blade to correct for corneal astigmatism right off the bat. I try to be just somewhat inside of the limbus so I don't get too much of the limbal vessels that can bleed throughout the surgery and obscure the view. The effect tends to be the same or even better for a corneal relaxation. I always try to use my secondary hand, 0.12 on the paracentesis to stabilize the eye while we're making these incisions, whether it's the primary wound or the LRI. And here you just saw the capsular rhexis. It gives you more stability against saccades from the patient, movement from the patient, as well as allowing you to rotate the eye to a position that's ideal for the capsular rhexis. When I do the hydrodissection and delineation, I find the space in between the cortex and the anterior capsule, put a moderate amount of pressure, and you can see a double wave on either side. Once I get a double wave, I'm quite confident that I don't have to rotate to ensure that the lens is free from its capsular attachments. You'll see that when I enter the eye here, you saw that the anterior chamber, I don't know if that was quite evident, but it expanded quite a bit. So the anterior chamber almost doubled in depth. What I'm doing with my secondary hand here is releasing the reverse pupillary block. So there's the pupillary block and there's a reverse pupillary block. And what happens is that the probe that's going in under BSS pressure is causing the anterior chamber to expand quite rapidly and deeply because the BSS is pushing the iris against the anterior capsule, causing a reverse pupillary block. And what I did there was that I turned my chopper 90 degrees and just created a space between the iris and the anterior capsule to allow for that fluid to equalize between the anterior and the posterior area, and what I mean by posterior area is the area between the iris and the anterior capsule. And this allows for two things. Number one, the anterior chamber to come back to its anatomical or physiologic depth, so you're not working in a kind of a deep chamber. Number two, it doesn't create as much distension against the iris and the ciliary body, causing a pressure feeling with patients. You couldn't hear here, but the patient there, when the iris did distend, is complaining that, I feel very uncomfortable because I feel he feels the pressure. And by doing the reverse pupillary block, or reversing the reverse pupillary block, I then ask him, how's the feeling of pressure now? And he finds that it's much more comfortable. So for patient comfort as well as for the ease of the surgery, I kind of keep that maneuver in mind when we have especially when we have a high axial length patient and a very distensible anterior chamber. I rarely see these in this type of effect in hyperopes or kind of normal axial length patients. So every time you enter enter the chamber under pressure, you may find that happens, and you have to be prepared with your second instrument or even with your primary instrument to reverse the pupillary block. Now, is it essential? No, it just means that the patient's a bit more uncomfortable, meaning they're a bit more jittery. And now also number two, you're working in a much deeper anterior chamber space, which means that you're working kind of in a little bit of a pit. Causing, and all these things tend to be incrementally more challenging for the case. So a routine case can become a much more difficult case with the patient uncomfortable and the anterior chamber so deep. Sorry, I'm a bit off center here, but as we center, you'll see the red reflex here. Same thing here. You see how that the iris expands? And look at that distension of the anterior chamber. And I'm using my primary instrument under foot pedal position 1 to put it in between the iris and the anterior capsule to release the distension. Now the iris does come down a little bit, which again does make it a little bit more challenging. But at the same time, it creates, you're trading it off for patient comfort, as well as a normal depth anterior chamber. So this can happen usually upon entry, and can even happen even while you're still in the eye, especially if you release the pressure and put it back on, and put the pressure back on, which recreates the reverse pupillary block here. You can tell he's got a bit of a floppy iris there, as you can tell from the viscoelastic going in. So I just moderately dilate the capsular bag with viscoelastic, and then the rest of the bag is opened by the little bit of viscoelastic on the end of my injector there. And there you go, distension again, right? But I do warn the patients. I said, hey, there's going to be a little bit of pressure. Please bear with me. See what I'm doing there? I'm releasing he's complaining of pressure, and I basically just release the reverse pupillary block. And there you go. That's my little tidbit on dealing with reverse pupillary blocks, highly distensible anterior chambers, just to make things a bit easier for these type of patients. Thanks so much. Bye-bye.